to allow the lung injury to repair itself. So it's not like you get a good blood gas, all right, got a good blood gas, all right, let's take them off, put them back on conventional. So they're recommending minimum of 4 days before you take them off the oscillator. So this is an adult on the ventilator with a 723 pH, a 69 CO2, 63 PaO2, and the saturation's 82%. We want to get the pH up to, what, at least 7.25. So we have to blow off some CO2. How could the saturation be 82% if the PaO2 is 63?
That's what I was gonna
That doesn't sound.
Maybe like 40.
Yeah, so don't you say at 82% would give you, what, about a 50 PaO2?
50?
Yeah, I would expect a 90 sat with that PaO2. All right, so let's go along with, they want us to improve oxygenation.
Okay.
What could we do to improve oxygenation?
Increase our map.
Okay, and it's at
32.
32, so we
Centimeters of
can
water.
increase that.
And then we can increase our amplitude to, I guess, wash out some of that CO2.
Very good. And then more amplitude would improve the CO2. Should we change the hertz? We know that if we turn the hertz down, we're going to get a bigger tidal volume.
That decreases CO2, so that could possibly work.
Typically, though, we don't, right?
Oh, right.
The hertz stays according to the body size. Even though we know if we turn it down, lower hertz, bigger tidal volume. When you slow that piston down, instead of it moving a little bit at high speeds, when you slow it down, it moves forward and back further, and that's why you get the bigger tidal volumes with the slower hertz.
So increasing MAP on this scenario would be an option, because we don't know what rib expansion is, what rib level.
You're right, so we could be over-distended and not know it unless we get an x-ray.
Mm-hmm.
So to go up on the mean airway pressure without a chest x-ray? All right, very good point.
Would you consider totally?
Mm-hmm. Yeah, so that's another thing to try.
Because you have, your amplitude is really high, airway pressure is really high, 32. You're okay with?
Yeah, I've seen amplitudes of 100 with the adults, and the big kids. Yeah.
And children as well?
No, it was like a 16-year-old.
Oh, okay.
Remember, an amplitude of 100 is 10 centimeters of pressure in the alveoli. So it's not like you're, yeah, I mean, as that oscillation goes through the airways, it really reduces down in its pressure.
I have a question.
Okay.
With the power setting, how does that help with the amplitude? Do you have to change the power setting to actually increase the amplitude?
Yes. Yeah, so you don't have an amplitude knob to increase amplitude. What you have is a power setting for the piston. So the more power to the piston, the greater the amplitude. Good questions. So here's another adult on settings, and got high CO2, low O2. Amplitude's at 100. Is there any information other than what's given here that might be of benefit?
Chest x-ray?
Chest x-ray. Very good. It's possible to over-distend the lungs, and when you have too much airway distension, it pushes on the capillaries going past the alveoli. And when you push on those capillaries, you slow down the flow. The blood is trying to flow past the alveolus, and it can't get there because there's so much pressure pushing on the capillary. So you actually reduce oxygenation if you have too much mean airway pressure.
What would be considered too much MAP? Is it the range?
Too much would be,
Is it more like what we'd be seeing?
it would be what?
Would we determine that on like what the patient, how the patient is? Because everyone's so different.
Yeah, so you'd look at your x-ray, and if you're over distended on your x-ray, then you would have too much mean airway
Minor
pressure.
Okay.
So instead of showing diaphragm as 10, now you're showing 11, that's too much, right?
Yes.
Ah.
Oh,
Okay. Yeah.
yes.
We had,
There's the answer right there in front of us. So the recommendation for this is to decrease the mean airway pressure because we're over distended, and then just monitor SATs to see if they improve. So do you get the connection where we're over distended, if we reduce the over distension, our oxygenation will improve? Just because now we're allowing better blood flow. Here's some settings, good blood gases, what do you recommend? And this is weaning, so I don't expect you to know all the ways to wean the patient, so we can skip this.
Whatever you say.
These look like some multiple choice quiz questions. Control of mean airway pressure is regulated by A, restricting the bias flow past the green balloon valve. You guys aren't going to know colors. What about B, using an external PEEP adapter? Obviously not. C, an electronic pressure transducer.
I think that's the one.
Sounds like that's made up. So it's the bias flow past the balloon valve.
Ah.
That's how you control the mean. So the correct answer is A. All right, next question. Increasing the power control will most likely result in A, a drop in minute ventilation and an increase in the PCO2. B, an increase in minute ventilation and an increase in the CO2. Or C, an increase in minute ventilation and a decrease in the PCO2.
C.
That's correct, letter C. So power control gives us the amplitude, the more amplitude, the bigger the volume, the more we get rid of CO2. A decrease in chest wiggle factor and a decrease in SpO2, an increase in the TCPCO2 might signal the following. A, improved compliance. B, a need for suctioning. Or C, a decrease in cardiac output.
B.
B, a need for suctioning. Very good. Can end-tidal CO2 be monitored with a high-frequency oscillatory ventilator?
No.
No. All right, now the jet ventilator, should I go through it now? Or
Sure.
you guys want lunch first?
Might as well go through it.
You can finish it. We only have a page left.
Okay. All right, so HFGAV stands for high frequency jet ventilation. So when you're just referring to high-frequency ventilation, you could be talking about the jet, you could be talking about the oscillator. So high-frequency ventilation is like the overall term. And then to be specific, you would say jet ventilation or oscillator, I guess. So with the jet ventilator, it delivers very short, high-pressure jets of air. And the exhalation is passive. With the oscillator, it was an active exhalation where the piston pulled the air back out of the circuit. With the jet ventilator, that doesn't happen. It only interjects air in and then allows exhalation to be passive. When you place a baby, I guess, or an adult, it can be used on adults, on the jet vent, you have to put a special adapter on the endotracheal tube. And do we have a picture? Nope. All right, so I need to show you that adapter, but it just has a little piece of tubing coming off of it, so you could hook up the bursts of air, or there's like a little box that pushes bursts of air into the circuit, into the endotube, and that's what the adapter is. It just allows you to add that. It's used in conjunction with a conventional ventilator. So the conventional ventilator will provide the oxygenation. The jet ventilator will provide ventilation. Do you want to add that to your notes just so you have that clear? I mean, why do you need a regular ventilator at the bedside if you've got the oscillator? And the answer is the oscillator, the jet vent. The jet vent will provide ventilation, but you need the conventional ventilator to provide PEEP and oxygenation. So PEEP and FiO2. This is a diagram I took off the Bunnell Jet Vent website. One of the PowerPoints has it on there. And it shows how when you push the air will go down the center of the endotube, and at the same time allow exhaled gas to escape on like closer to the wall of the endotube. So you've got inhalation occurring down the center of the tube, and on the outside, not the outside, but the side of the endotube, you've got exhalation occurring at the same time. And it says this helps to move secretions toward the endotracheal tube. All right, so I need to update my picture because now instead of them using the Avia for the conventional ventilator next to the jet vent, they have a little tiny, maybe like a 10-inch by 10-inch ventilator that they put next to it. So instead of having all this equipment at the bedside, it's a lot smaller now. All right, so typical settings for the jet ventilator. So starting off, you start off with a rate of 7 hertz. And that gives you 7 times 60, 420. So a respiratory rate of 420. That's a little bit slower than the oscillator, isn't it? So the jet vent has rates that are slower, because this is on a neonate, a rate of 7. Peak inspiratory pressure, 18 to 20. Or you start with the same peak pressure that you had on the conventional ventilator. Your I time, you start with 0.02 of I time. FiO2, whatever is needed to get your oxygenation in range. And then the PEEP and backup SIMV are set on the conventional ventilator. So the backup SIMV rate is typically slow. Like it's not, we talked about a typical respiratory rate of a neonate being about 40 breaths per minute. So when you first put them on a ventilator, you set a rate of 40. The backup rate on conventional ventilation, when it's just the backup for the jet, it's a much slower rate, less than 10 per minute. What were you saying, like 6? You had 40?
The baby that we had on Friday, she was on the back of 3.
3 breaths per minute. Okay.
You're like 40.
Very slow. So it's thought to just improve or to prevent atelectasis from happening. If once in a while you give a bigger tidal volume, instead of little tiny jet vent breaths, you give a bigger tidal volume once in a while, and then you're going to prevent atelectasis from occurring. All right, and then I want to tell you about servo pressure. And there's a slide on servo pressure. We'll go to the website in a minute. What I want to do is explain servo pressure to you, and then we'll read that slide. So when you're ventilating lungs, and you're ventilating a big area, you've got a big set of lungs, it's going to take more servo pressure or more work of the motor to ventilate a really big lung. If you have a little tiny lung, the motor is not going to have to work as hard to ventilate a little tiny lung. So the servo pressure will be less if you're ventilating a small lung. All right, so do you have that concept in place? Big lung, a lot of servo pressure, little lung, little servo pressure. All right, so this is how they're using it at the bedside. They have they'll notice a normal servo pressure when they're ventilating the neonate. And if the servo pressure drops, that tells them that they're ventilating a smaller area. Well, ventilating a smaller area could mean that you've got a pneumothorax. It could mean that your secretions have plugged up some areas of the lung, you're not ventilating. It could mean atelectasis. So they follow the servo pressure really close, and if they see it dropping, that tells them, hey, let's figure out why we're ventilating less lung area. So when compliance improves, and when compliance improves, you've got a little more volume going into the lung, you'll notice that the servo pressure goes up. So it goes down, occlusion, or you can think of it as occlusion, goes up, you're ventilating more area. All right, let's see what the slide says. The servo pressure is the driving pressure that provides flow. Servo pressure changes as lung volume changes. If you see the servo pressure increasing, you're delivering more volume. That means that your volume has increased. If the servo pressure decreases, that tells you that the volume you're putting in the lungs has decreased. Servo pressure changes indicate an early warning of patient changes. So if it increased, you've got better compliance or maybe better resistance. It could mean some other things, like you suddenly have a worsening of an air leak, or you could have some leaks in your tubing. So it's not always a good thing when you see an increase. A decrease, now you're ventilating smaller lung. Why are you ventilating smaller lung? Well, it could be that the compliance is worsening, the lungs are getting stiffer, so you're not ventilating as well. You could have a pneumothorax, or it could be that the patient needs suctioning. All right, so that's servo pressure. Does that make sense? Because that's like a big thing with jet ventilation, is understanding the servo pressures. Danielle, do you have anything to add to it, to help clarify it?
No, while was monitoring the neonate's pressures, and he went up on it, and she was at 3.1. He says that was different, that means that she's barely ventilating, because before she was at around 2.7. that it was an increase, and he was like, that's much better, because he went up on her pressures on the jet ventilator, and her servo pressures also increased that.
Ah, so I guess the next step is knowing what vent changes to make if you've got good.
Servo
yeah.
pressures, yeah.
Servo pressure. And what do you mean by servo pressure? That's like is that like it's on the perimeter? That's
Yeah.
on the jet or?
It's on the jet
It's on the
ventilator.
Yeah, you'll see a little thing that says servo
It's
pressure.
monitored, it's not
And
something
they'll-
simple.
Yeah.
Correct. It's just monitoring how hard the motor's working to ventilate a lung. And when the motor's not working very hard, it's not ventilating much lung. And then the opposite can be true also. All right, so we're ready to go to Benel.com. I'm looking for they have like a virtual jet vent and you can play with it. Does it go on? I don't want a video. I don't see it. Oh my word. Maybe here? It's a PDF. All right. All right, I'll look for it during lunch. I don't see it though. You can see all the monitored values showing up in the bottom right of the screen. Your peak pressure and your delta P. The PEEP, the mean airway pressure, and the servo pressure. All right, so babies that have BPD do well on the jet ventilator because, do you remember what BPD is?
Pulmonary dysplasia,
Mm-hmm. And what causes it?
being on the vent for 36 weeks or more.
Yeah. So mechanical ventilation, high FiO2s are damaging the alveoli. So how do you allow the lungs to repair themselves? They can go on the jet. So babies with BPD do well on the jet. If their chest x-ray shows hyperinflation, which could happen because their lungs become just like COPD lungs, where there's a lot of air trapping in their lungs. So if they have a lot of air trapping, there isn't going to be a backup rate from conventional ventilation when you put this baby on the jet vent. And then the other change, if there's high CO2 in the BPD baby, what they do is give it a longer I time. So on the jet vent, you typically stay with your 0.02 seconds. When would you change the I time? With these BPD babies, you want better ventilation, give them a longer I time, and you'll get better ventilation. But to give them more amplitude when their alveolar structures are already damaged, you try to avoid that, so a longer I time.
Is it longer I time or shorter?
0.02 to 0.034, isn't that longer? With an air leak causing pulmonary interstitial emphysema, will increased IMV rate on the conventional ventilator improve or worsen the amount of leak? And then it wants us to watch a video and make the decision. All right, so the IMV rate on conventional ventilation. Wow, we get some music. It sounds like it's just a commercial for high frequency, or for the jet ventilator. Okay, oh, here we go.
This video is intended to demonstrate the difference between PAP on the conventional and PAP on the high-frequency jet ventilator. Here you can see how the conventional ventilator is set at a rate of 20, but most importantly, a peak inspiratory pressure of 20, a peak of 5. The jet ventilator is set at a PAP of 30, and there it is trying to reach 30 on the monitored display. So the important part of this demonstration is that the jet is delivering a peak inspiratory pressure of 30, while the conventional is delivering 20. When I show just the conventional breaths by themselves, you can see very aggressive bubbling out of the leak that I've created by removing one of the balloons from the muscle. Most of the air is exhausted through the leak, and very little, if any, is getting to the alveoli. So the peripheral alveoli are being robbed of tidal volume because most of it is being exhausted out of the leak. Just imagine if that was a pneumothorax or BNE. With just the life pulse running, you can see that there's no bubbling out the air leak. The peripheral alveoli are being ventilated, as indicated by the wiggler. Even the ones adjacent to the leak are receiving some degree of ventilation by the jet ventilator. And there's no active bubbling through the air leak that I've created in my testing. When I run the two together, remember the conventional ventilator PIP is at 20, the live pulse ventilator PIP is at 30. Both ventilators are running at the same time, and you can see whenever a conventional breath comes, again, very aggressive bubbling out that leak. Most of the gas is being exhausted. The live pulse is much more gentle, much more effective at ventilating. It's ventilating the peripheral alveoli without aggravating the air leak.
You can see how much more gentle it is, don't you agree?
Even with 10 centimeters of water more pressure, the jet ventilator is more gentle. So you will have to give a few side breaths if you're doing a temporary recruitment maneuver to reverse atelectasis. And you can see why it's so important to get rid of those conventional breaths once the lungs have been recruited and PEEP stabilized, inflated alveoli. The moral of the story really is that raising the jet PIP with a high-frequency jet ventilator life pulse PIP is much safer and more effective than raising the conventional mechanical ventilator PIP.
He's calling it pip.
He's fired.
Yeah.
Oh, that's it. So, if you could tell me normal settings when you place the baby on jet ventilation, and then normal settings for placing the baby on an oscillator, you're going to be pretty good to go. And the other thing is, what do you change in order to get your blood gases? And if you have a BPD baby, is it better to have a high IMV backup rate with the jet vent? Or is it better, no, I didn't say that right. Is it better to have a short inspiratory time with a BPD baby or a longer inspiratory time with a BPD baby?
Longer
inspiratory time. You have a baby with a bronchopleural fistula. Is it better to have a high IMV backup rate or no IMV backup rate?
No, I need to be back up
You're good to go.
there.
So we'll have lunch and then, I just have a little bit left after lunch.